So we're going to start the session. Dear colleagues, welcome to this Medtronic-sponsored session on the evolving landscape of TAVI. And over the next hour, more or less, we will explore how TAVI is redefining the management of aortic stenosis from the latest data and expanding indications to innovations and procedural efficiency, coronary access, and also the transformative potential of artificial intelligence. So I think TAVI rapidly, Nico's coming here, rapidly progressed from a therapy for patients not having options or high-risk patients to mainstream therapy, and I think that is driven by long-term data and technical advancements we nowadays have. So as we broaden eligibility, new challenges arise, so ensuring equitable access, optimizing lifetime management in these patients, procedural efficiency, and also guaranteeing coronary future access to the coronary. So I think AI is going to be crucial to play a pivotal role in this, in streamlining workflows and improving patient selection and shaping the future of TAVI. And I think we have distinguished speakers here to learn you more about this. So my name is Martin Zwaans. I'm an interventional imager from the St. Antonius Hospital. It's my pleasure to chair this session together with Nico Piazza. We have Matti Adam, Birgit Konska, Antonio Mangieri, Anna Vera Marinho, and Francesco Saya. And I think we hope to keep this session interactive. So maybe, Nico, you can explain how people can interact with us.
Yeah, so you'll see that there's microphones around the room, so we encourage you to come up and ask any questions you like. You can also use the app to ask questions, yeah, feel free to engage with us and ask anything you like.
Good, excellent. So without any delay, I would like to ask the first speaker, Birgit Konska, to come to speak about the navigation, the future of TAVI, so current guidelines, emerging trends, and demographic shifts we're going to have. The floor is yours.
Well, dear colleagues, it's a pleasure to be here at this Medtronic session at EuroPCR. I'm an interventional cardiologist from Germany, and I'd like to go over the current guidelines, what are emerging trends in aortic stenosis treatment, and what are we expecting due to demographic shifts. These are my potential conflicts of interest, and just a quick reminder, these are the current guidelines, the American ones from 2020 and the European ones from 2021. I don't want to go too deep into that. It's just that they're focusing mainly on severe symptomatic aortic stenosis, and they set an age cutoff for treatment indications, either surgery or interventionally, which is 75 years and above in the European guidelines, more conservatively, and 65 years and above in the American guidelines. And with these guidelines in place, we've seen further increasing numbers. These are numbers from the German Heart Report, increasing numbers in TAVI treatment, and the same trends can be observed in the American guidelines above in all age groups, and which is really interesting. Even in the age group below 65, we almost have a 50-50 ratio treating patients with aortic stenosis, either with interventional catheter replacement or surgical valve replacement. However, even though numbers are increasing, there's something I'd like to point out, and that there's a persistent treatment gap for women with aortic stenosis, which is not a little hard to understand because prevalence of the disease is the same in women as in men, but still women receive less often treatment for this disease. This is an overview of European countries. And you see the disparity there. On the blue graphs are men being treated for aortic stenosis, and the red ones are women. So something we have to look out for, be conscious about, I think really important for the future. So with the current guidelines in place, there are emerging trends when it comes to other patient groups, maybe other indications treating patients with for aortic stenosis, and that is of course younger and lower risk patients. Just one of these trials maybe is Notion 2, who compared patients 75 or younger with aortic stenosis treatment with a surgical approach or an interventional approach, and there was no difference basically in the combined endpoint outcomes. There's something about asymmetric aortic stenosis, as it's mentioned briefly in the guidelines, but only if it has really high gradients, if it has signs of heart failure, then it should be treated. But what about those patients that have, like, by accident or by choice, the diagnosis of a severe aortic stenosis? And this is one trial including 900 patients above 65 years with asymptomatic severe aortic stenosis, which means they had done exercise tests and they didn't show any symptoms then. And you see that treating these patients had a significantly better outcome in the combined endpoint compared to surveillance. However, this endpoint was driven mainly by hospitalization to cardiovascular disease, not by the hard endpoints, death and stroke. Moderate aortic stenosis is not something benign. This is data from a meta-analysis of over 400,000 patients that were looked after with moderate aortic stenosis and mild or non-aortic stenosis, and patients with moderate aortic stenosis had significant less survival over the years. So maybe this is something we should also treat. There are currently trials going on that topic. One has already been published as the TAVI Unload trial, including roughly 180 patients with moderate symptomatic aortic stenosis and also reduced ejection fraction. This trial didn't show any severe, like there wasn't any significant difference to the surveillance group when the patients were treated. However, quality of life after 1 year was better in these patients group. Two other trials, the Evolute Expand TAVR 2 pivotal trial with the Evolute valve and the Progress trial with the Edwards valve are still recruiting, to my knowledge. And also we have these emerging indications which will rise our numbers probably with the current guidelines, which we are expecting this year, the European ones. There's something completely different. That's the demographic shift. Life expectancy is going to rise in the next decades, as you can see here. And with that comes an overall rise in the global population, but also the percentage of elderly people is going to increase. So that puts us into a difficult situation with facing a growing TAVI population. And at my center, we already have a waiting list, and probably most centers have the same thing too. So what do we do about that? Can we streamline patient pathways with maybe minimalistic approaches? How do we maintain our really high quality with this treatment if we have to manage an increasing throughput? And maybe artificial intelligence can help us a little bit with doing a smarter triage and workflow management. So the future is interesting but challenging. Thank you.
Thank you very much, Birgit, for setting the stage. I think interesting topic. You already highlighted the things we're going to discuss here, because it's a big challenge with all new indications coming from TAVR, more data is coming up. And I'm curious to hear a little bit from the panel, because we know, and that we can't look in the future, but the guidelines are coming up. So what do we think the biggest changes will be in the guidelines upcoming? And for example, we see patients now being treated below 65. We know their risk profile is a little bit higher, but still, do we already have enough data to support treatment for these kind of patients? Maybe Matti, what do you think?
Well, that's a great question. I mean, I don't know. I'm not an oracle, right? And I don't want to be in the shoes of the guys writing the guidelines right now, because I think some topics are actually quite interesting, and you have data for like both arguments. You know, I think one of the main questions will be, is early TAVR, for example, going to affect the guidelines? Yes or no? But that's a difficult question, right? Because, as you said, there's no hard endpoint. It's a lot of hospitalization going on. But I mean, I think we can show that TAVR is safe in these early patients, but I'm not sure if we should treat all these patients early. And then, still data coming in. We'll see a lot more of that from, how long a valve's going to last, what's your valve strategy. So it's a difficult topic. I don't know, Martin, what do you think?
It's a very good question. I think the early TAVR is going to be interesting to see if it's already enough. Indeed, hard endpoints we do not see. I think And also looking at the moderate AS, it's all indicating, I think we have more and more, and hopefully more data will come soon to support, I think, especially you have a low risk, more or less low risk procedure. And I think that's completely something else than having with surgery. So I really believe in the concept also for moderate AS with cardiac damage that some of these patients, and I don't think all these patients will need an earlier treatment. We need to, find these patients. I think also there, and that maybe will come up in one of the talks later on, but I think AI, but also the way we follow up these patients at the moment, so we see them back after a year or 2 years, it's all the same. But I think if we look now with all these apps being available and patients can send in how they are feeling. So I think with the future we can identify these patients earlier and that they let us know that they're becoming symptomatic and we can easily start working them up. But Nico, what do you think?
Yeah, I wanted to say, one of probably the most interesting part of the presentation for me was the last slide at the end. I mean, what are the solutions that we're looking at to manage these emerging trends? So, for instance, Francesco, let's go to your hospital. You may have a TAVI waiting list. Do you have any ideas of what we can do at the hospital level? Is there a pathway that you're using? Are you getting your patients with a CT scan immediately from the referring physician, or are you waiting to see them in office before? What are the type of things we can do in order maybe to streamline our patients?
Yeah, thanks, Nico. I will address some of these issues during my presentation, but of course there will not be time to deep dive into each step. I think we have several opportunities at every step of the patient journey of TAVI pathway. So from the pre-hospitalization phase to the hospital to the post-procedural course, and everywhere there is an opportunity. To address a little bit your question more, for example, one of the tricks that we used in my hospital is to manage directly the list of CT scan. We had an agreement with the CT scan department in order to manage ourselves, so we can optimize the timing between the CT scan and TAVI, and even use these slots that we have. We manage ourselves in case, for example, it happens everywhere. A patient the day before TAVI, 2 days before, just say has fever, cannot go to the hospital, and so we can replace this. But this is one of the really many possibilities that we have to optimize.
Yeah. Anyone else on the panel have any other tricks to streamline patients?
I agree with Matt, because we know that in next years we have a lot of patients to treat. If the guidelines change, in the proximal guidelines change, a lot of people we need to treat. So it's the time to optimize our programs in order to treat now the patients that we have in a waiting list. We have waiting lists is so long. With these guidelines, when we have another indication for more lower risk or more younger patients, we have more patients to treat. So it's the time to optimize the the TAVI admission and the post-procedural period in order to optimize and streamline the TAVI procedure.
So excellent, yeah, Vic. So I think we've seen many data already that death on the waiting list is absolutely not rare, and I think from England we have seen that we see more and more urgent TAVRs, so they're just waiting for a TAVR, and then more and more patients being treated in an urgent way, and we know that mortality in these patients and complication in these patients is much higher. So this is a problem we already see coming. So I think it's a very important session to discuss some of the issues we're going to face. So I think for the sake of time, we will get back to that a little bit more. But maybe, Matt, you can tell us a little bit more about the data at the moment supporting the lifetime management in aortic stenosis TAVR patients.
All right. Thank you. Thank you very much for having me. Thank you guys for hosting this session. And my point here is going to be, if you future-proof your TAVI program, so what's maybe the vital or what's the role of data in lifetime management? And as we only have 5 minutes, lifetime management, I mean, we could spend the whole session talking about lifetime management, right? So when you're breaking down lifetime management, what are the questions that you actually want to answer? And so you have, and Birgit touched on that, we have more life expectancy, we have an expanding patient population in age, in indications. So that's one part of the problem. Then we have durability of the devices that we are using. We need long-term TAVI trials. And we have to look at hemodynamic performance. And then there's also the redo aspect, valve and valve, TAV and TAV, which Evolut has an indication now for. But this is a topic that I will not touch. We should have an extra session on this, right? I think this is a great topic. But let's talk about life expectancy, durability, and what do we know. So again, Birgit showed this already. So the life expectancy also the mean age is really decreasing in the US. So we have many patients in the US, like more than 50% or around 50% that are treated and are under 65 years of age. And if you treat older patients, for example, like we in Germany, our average is still 79, 8-ish. You want a valve that's good for 6 years or 7 years maybe. But if you treat younger patients, you need a valve that's going to stay there for 12 or 13 years. So you need really good decision making for your first valve, right? And so if we look at the data that's out there, that's, for example, the 5-year outcomes. We want to talk about the 5-year outcomes of the Evolut low-risk trial. And just to remind you, what was that trial? The trial was a 1-to-1 randomization of TAVR versus SAVR in low-risk patients, right? And if we look at the endpoint, the primary endpoint, it's all-cause mortality or disabling stroke, we see there's clearly an absolute non-inferiority for the TAVR group, which is the Evolut group, against surgery, right? So it is a very good technique to treat our patients. They are alive as well. They are alive and well with KCCQ measurements. They have no PVR, no significant more PVR than the surgery group. The patients we treated with TAVR, we have a very good hemodynamic valve performance with the EOA of above 2 and a gradient around 10. Even after 5 years, no signal of deterioration. So I think it's pretty safe to say that hemodynamic performance in these cohorts is good over 5 years, right? But also, we have no difference in reinterventions between the Evolut and the surgery group, and we have no difference in bioprosthetic valve failure. Why is this so important? Because bioprosthetic valve failure is, of course, one of the things that, if we speak about lifetime management, we don't want to have. And one part of bioprosthetic valve failure, is valve deterioration or valve dysfunction. And there is a group of patients that are probably and a little bit more prone to BVD. And it's also a group with smaller annuli. And it's also referring to a group that we sometimes don't see that much in TAVR cohorts, like women, and Birgit touched on that topic, because small annuli are more common in women. So, and if you look at the SMART trial, which actually randomized Evolut against Sapien in patients with annuli lower than 430 square millimeters, then you'll see there's a huge difference in these patients in terms of hemodynamic outcome. And you see in the blue group, that's the Evolut group, you have a higher EOA, you have lower gradients over time now, that's 2 years result now. The mean gradient, so the definition of valve dysfunction, right? Mean gradient above 20 is 22.7% in the Sapien group, versus 1.2% in the Evolut group, and the DVIs are 0.6 in average, which is hemodynamically a good sign. So if you define bioprosthetic valve dysfunction hemodynamically or non-hemodynamic structural, then you'll see that the difference is like striking. You see that in Evolut, bioprosthetic valve dysfunction through 2 years is 12.5% versus 48.4% in the Sapien group. So I think it's pretty important to talk about this. And if you look at the size distribution or at the annular size, you'll see that it's even more important the lower your annular size gets. So the smaller your annulus gets, the more important it is to put a valve in that has, in the end, good valve performance. And then there's always the argument, hey, it's only echo gradients, right? We need to see if that's actually, tracking to how our patients are after a couple of years. And absolutely sure, true, we have to wait for data of SMART that's like 5 years. So this trial is going to be continued, right? But if you look at the low-risk data, Evolut low risk, and you'll see that the patient that are defined with BVD in the surgery group, and in the surgery group we know high gradients are bad, right? So if you look at the surgery group, you'll see that BVD is actually correlating with higher all-cause mortality and endpoints, right? And the same is true for the group that is treated with Evolut. So it might be a signal that we have clinical impact on echo gradients in our patients. Like, to summarize, I think in the increasing popularity among younger patients, we need to think about lifetime management. I think we need to understand lifetime management and hemodynamics, and I think we also need the trials to go longer, to report regularly, and to actually go as long as we can, just to see how valve performance is over the years. Thank you.
Thank you, Maddie. So, this lifetime management is something important, of course, and we're looking at, the potential obstacles we'll need to face in the future after implanting a TAVI valve. Can you give us your perspective of how you deal with patients in terms of choosing a balloon expandable versus self-expanding valve, thinking for the future? Also, to make clear is that, now with the Evolut FX Plus, you got the big windows. Really, we're not worried about coronary access anymore, and especially that you can get commercial alignment. So taking that out of the equation, because, coronary disease for me doesn't play a role anymore. What are the other things that you look for when choosing between balloon and self-expanding long-term lifetime management?
That's a very good question. I would agree, Nico, that coronaries, that's not a problem anymore. I think that's addressed through the iterations of the device that, they play very well along with what lifetime management looks like for patients, I think. And I mean, every center has to find its own way of tailoring, which device you want to use. And of course, it's experience and what you have, different platforms you can use. But I'm a smart believer, for example. So, 100% sure, if the annulus is small, we will definitely go for a supraannular valve. This is one of the examples, right? And then you have to, of course, I think the important thing is, and we have an imager on the panel as well. So you really need to make sure that you understand the whole anatomy of your patient, access, horizontal aorta or not. But the thing is, when you're experienced, you can pretty much put any valve anywhere, right? But I think you have to find the right patient, as you said. And for me, one of the examples, for example, is the small annular where it's a no-brainer, right? And
okay.
No.
Okay. One of the things, because we're talking lifetime management, and you showed very nicely, if you go to younger patient, the chances that these patients will need a second TAVI valve or anything. Looking a little bit in the future again, what do you think is the role of simulations or these kind of things in these kind of patients, where you can already sort of plan your future strategy in these patients? What do you see for that?
Well, I think that's a very important thing. I think I might try to stretch the point that I think the first valve is important. So if we have great valve performance with the first valve, we might not end up thinking about a second valve. But of course, you have to keep that in mind. That's per definition lifetime management, right? But I think simulations can be super helpful, because if we talk TAV and redo, then it gets way more complex very fast. And simulations can help you to understand, is this a patient where I might where I might run into a coronary problem very, very, where I will run in a coronary problem that's really, really hard to solve, only with leaflet modification and so on. So that's probably affecting how deep you would implant your index valve and all that. So it's really a lot of thinking, and I think visualization, simulations, that's really important to help us understand that.
In fact, nowadays we frequently see if we do a redo TAVR, then we end up with a situation we didn't think of in the beginning, and then we end up with the problem.
Exactly.
So I think
it's like a bad surgical valve, right? Those should not be around. They are around, so we have to deal with them. Let's try not make the same mistake for TAV and TAV, right?
Good. Please remember, if you have any questions, go to the mics. And there's only one question here on the computer that does not relate to the lecture, so I'm not going to say it at the moment, but please try to interact as much as possible. Thank you.
Excellent. So thank you, Matthew. We'll move on. And now I would like to ask Anna to come forward and to discuss the pre-TAVI precision strategies for achieving optimal patient outcomes.
So, good morning, everyone. Following this discussion, I will focus on strategies for achieving optimal patient outcomes during pre-TAVI evaluation. This is my disclosure. Why this important? This problem is important. The aging of the population and the expansion of TAVI indications to younger and lower patients and low-risk patients will lead to a substantial increase in the number of TAVI procedures performed within the next years. So, there will be an increasing need for a simplified and fast-track TAVI approach in order to treat these larger patient flows at a reasonable economical cost. So the question is how we can increase the efficiency of a TAVI program, particularly before TAVI implantation. The first step is the adoption of a hub-and-spoke model for treatment of a heart valve disease, with heart valve centers and the other peripheral hospitals with well-defined networks and protocols for referral of patients. Furthermore, for a successful and high-quality TAVI program, selection of patients and the patient-centered decision is fundamental. So, all patients should be discussed in a multidisciplinary heart team, including cardiologists, intervention cardiologists, cardiac surgeons, anesthesiologists, specialists in imaging, dedicated nurses, and others. So all together, we'll be able to decide or to the best treatment for each individual patient. Another important point is the waiting list. In fact, with the increase of waiting lists, TAVI centers should apply prioritization criteria in order to minimize the waiting time for the most serious patients. The majority of patients are admitted for TAVI are outpatient patients, are elective patients. So when we schedule patients monthly, weekly, we need to take into account the urgent patients that need to be treated faster than elective, than stable patients. Regarding this problem, remote monitoring programs can be useful tools for patient learning and improve the communication between TAVI centers and the patients. The TAVI centers should have a pre-procedural checklist that can help the team to track the workup progress and avoid unnecessary delays in the pre-procedural evolution. So this checklist should include, obviously, a transthoracic echocardiogram, and in patients with low flow, low gradient aortic stenosis, a dobutamine stress echo. An ECG allows the heart team anticipate the risk of disturbance or conduction disturbances and identify the patients that probably need to prolong their stay after TAVI. Assessment of coronary arteries is also, before TAVI, is also standard practice. The guidelines recommend the treatment of significant lesions at the proximal segments. However, the decision regarding the treatment and the timing of treatment before, during, or after TAVI should be done by the heart team on an individual basis, depending on the complexity of coronary disease, the timing, the leading problem of the patient, and the comorbidities like a kidney function or the bleeding risk. The checklist should include a basic blood tests, namely the kidney function. We know if you have a patient with a chronic kidney disease, particularly if the patient has diabetes, we know that this patient has a high risk of contrast nephropathy. So we should do prophylaxis of contrast nephropathy in this patient. Anemia is a very frequent problem in aortic stenosis population. So we should optimize these values before TAVI admission, in avoiding the unnecessary transfusions after TAVI and prolong the stay in the hospital. The CT scan. The CT scan analysis is furthermore important in pre-procedural planning. It allows not only determine the balloon and prosthesis size, but also the feasibility of the transfemoral access and anticipate potential problems as risk of coronary obstruction, rupture, annular rupture, or vascular complications. This analysis should be done as early as possible, allowing a more careful and accurate scheduling of procedure. Probably the most centers that do TAVI with the alternative access do it in a specific days with support of vascular surgery and anesthesia, for example. So you need to know this information with time. Another point to optimize a patient before TAVI is to take a full picture of the patient. We need to know about the functional states of patient, about the frailty grade of patient, if the patient has sleep disorders or chronic pain. We know that this patient has high risk of delirium during the admission. We need to know about the social and family support in order to address these issues before admission. There are several scales to measure frailty, such as this 4-item scale that is quick and easy to perform and has a predictive value and most important, identify points of intervention that can reduce the risk of patient. For example, identify patients that probably should be included in a rehabilitation program after TAVI. Last but not least, for optimizing their TAVI program, the centers with high volume TAVI program frequently have a TAVI coordinator. What is the TAVI coordinator? In my opinion, TAVI coordinator is a facilitator. They have an active role in all steps of TAVI pathway. Streamline and prioritizing the referrals for TAVI, waiting list management. It's a point of contact for patients and other hospitals. Organization of the heart team meetings, coordinating the care out in inpatient settings, and maintain the TAVI members, all TAVI members connected and informed. This is a slide, this is a flow chart of all key procedures that streamline TAVI program in order to optimize for its example. So in conclusion, in my point of view, in order to optimize their TAVI program, the centers should have a heart team with regular meetings, have a TAVI coordinator, develop and follow standardized protocols regarding pre-procedural planning, have a dedicated TAVI team, and adopt the idea that discharge begins before first visit, with first visit and not with discharge of patient. Thank you so much.
Thank you very much. Excellent talk. And there's a lot of questions coming in, so we're going to answer them in a second. Thank you very much for that. But first, we're going to hear a little bit more about optimization strategies for in-hospital. So, Francesco, please go ahead.
Yeah, and we will get to your questions, so keep on asking. Yeah. There's quite a lot that have come in after your talk.
Thank you very much. Well, we're talking about strategies of optimization, and I will focus on the hospital phase. Those are my conflicts of interest. We have been talking about the increasing number of TAVI. It was a little bit there, not exploded, the problem of the waiting list, which is not a benign disease. You can see these French data. The mortality in the waiting list is between 5 and 6%. And in 63% of the cases, it happens within the first 2 months. So waiting list is an issue. And if we have a look, again, France is a country with a high volume of TAVI. So it's not a country in which we expect a very high waiting list. And you can see that there is a difference between TAVI centers, of course, and non-TAVI centers. But importantly, over the year, this list has not reduced. It has increased. And in France, you see that recently the median waiting time for TAVI is 97 days. So it's still something that, is the rationale for optimization of the TAVI pathway in every stage. In order to increase the number of TAVI procedures that we saw already, will increase further in the next few years, there are different potential strategies. Of course, to increase the capability of TAVI centers, heart valve centers to provide more TAVIs, hub-and-spoke models for referral centers, and also, the hypothesis of performing TAVI in centers without on-site cardiac surgery. I will not talk about this last, that is quite controversial. But anyway, if we focus on optimization of hospital pathway, it will impact both, the every step that even if you think about increasing the numbers of TAVI in the heart valve centers or hub-and-spoke models. So this is, I think, is key, is very important to increase the number of procedures. And we have been watching now what can be done before the procedure. I will focus more on everything that can impact of the length of stay. That you can see the factors that impact on length of stay are in every stage of hospitalization. So from the TAVI procedure to the immediate post-procedural course to the timing of discharge of the patient. And in every one of these steps, we can do something to optimize, streamline, and at the end of the story, increase the numbers of TAVI and our offer of TAVI. This is not anymore an opinion. I will not share with you only opinion, because now we have several data pointed out that this is feasible, is safe, and effective. And you can see here FAST-TAVI, 3M, benchmark, FAST-TAVI 2 trials, different countries, different protocols, a little bit different patients, different endpoints, but the results are always the same. When you put in place some protocols for optimization, this is associated with effective outcomes in terms of reducing hospitalization and shortening the time of length of stay, and also without compromising safety. One of the key factors for in-hospital optimization is the TAVI coordinator. We just heard that. This is important in the pre-hospital phase. This is important in every steps afterwards. You can see that we can pursue to try to have same-day admission, or any way to keep very short the timing of admission before the procedure. We need to have everything checked in terms of the patient documentation and medication in order to avoid any surprise during hospital admission. It's very important. This is key. Communication with the family and the patient. The patient and the family should be ready, prepared to the fact that hospitalization for TAVI is a short one. They should not be expecting many days after the procedure. And anticipation of any potential issue. This comes with, of course, planning of the procedure. This is very, very important. In terms of the procedure, minimalistic procedure, I think nowadays should be the standard of care. But when I talk about minimalistic procedure, I want to stress this point, that the planning should be maximalist. There cannot be surprises. So this is, at the end, comes from a strong teamwork. Safety protocol must be in place. You cannot compromise safety for efficiency. The planning of the procedure should be meticulous, and this is the most important point, in my opinion. Every step should be standardized. This is really the way to go. Every step, pre-procedure, intra-procedure, post-procedure, and this is very helpful for all the team involved in the procedure. What in my mind, a streamlined TAVI is a TAVI with the patient fully awake or conscious sedation. Transfemoral access nowadays should be echo-guided. This reduces importantly the vascular complication. Secondary access transradial, this is not essential, but I think it's helpful. temporary pacing, I mean, pacemaker should be removed very early, or left-right pacing, or anyway, you should have in place protocols for, management of conduction disturbances to keep temporary pacing as short as possible. And then you can skip admission to the CCU in most of the patient, and the patient can be immobilized very early and discharged early based on some protocols. These are data from my center. These are all data. We have now been working for more than 10 years sending the patient back to the ward instead of the CCU. And this data showed that this is feasible, is safe, there are no issues, provided you do it with a clear and standardized protocol, keeping in mind that some patients, of course, cannot go this pathway. We cannot go into details, but of course, for example, in our experience, we have two hours of semi-intensive monitoring in the cath lab. But you can do differently. There are several examples in the literature of optimization of minimalistic TAVI procedure. This is a similar one, another center. So again, you can see the features are the same, the characteristics of a minimal procedures. And importantly, you see again, mobilization after 6-8 hours is feasible, this early discharge is feasible, and it's very important to have pre-specified discharge criteria. So this should not be, something that is occasional, it should be well standardized, possibly with a checklist. And you see here the results of this center. This is the center of Catania, that 50% of the patients could be discharged day one, and around 70% of the patients were discharged within 48 hours. And in terms of safety, there were no issue. You see that actually the clinical results, if any, looks a little bit better. One of the most limiting factors for early mobilization and early discharge is the management of conduction disorders. Now we have a lot of factors predictive of disorders. We know that anatomic features, baseline ECG alteration, procedural aspects. This is something that can be put into some algorithm that you can either take from the literature or develop for your hospital, but it's very important that this should be standardized. And one factor that has been overlooked in the past, it's not, we should focus not only on the immediate risk of pacemaker on the overall. What is sometimes limiting for early discharge is being able to predict which patient will develop a delayed AV block. So this is a paper that we published recently in your intervention trying to address this factor. And actually we see that with using some factors, a mix of procedural anatomic factors and baseline factor, you can distinguish three groups of patients: low risk, intermediate risk, or high risk of delayed AV blocks. And for example, low-risk patients, they have less than 0.5% risk of delayed pacemaker. So you can discharge this patient without any risk of late conduction disturbances. Intermediate risk maybe is worth monitoring 24 hours more. High-risk patients is better to implant a pacemaker or maybe monitoring for a long time. So it's something that can be done. I just wanted to show you some data, just not to say only opinion. And again, mobilization, 6 hours is very safe. And I can say more, even 3 hours could be safe. This is a paper coming from the group of Ole de Backer. You see that the comparison between 3 hours and 6 hours, even at 3 hours, there are no safety concerns. So the patients can be mobilized early, again, within safety protocol that you should have in place. So in conclusion, a TAVI pathway includes optimization of all steps of hospital staying of the patient, from the admission to the procedure to the post-procedural course. And this optimization is key to enhance hospital efficiency and to increase the number of TAVI procedures. Thank you.
Thank you. Thank you, Francesco.
Yeah.
Okay, so yeah, Martin, you're smiling because we've been looking at this screen, and there's been over 10 to 12 questions that came back to back. Probably we can classify them into 4 or 5 topics so we can touch on everyone's questions. But interestingly, there's one topic here that has been asked by over 5 people, and it's a little bit surprising. And I want to make sure these people are not all sitting together. Jan Sitar, where are you? Jan Sitar, there you are. Davor Vukadinovic, over there. Okay, so you're separated, okay. And you're not friends, right? No. Okay, look, the question that was asked by about 5 or 6 people, and maybe I ask you, Antonio, and I'm going to phrase it in a way that is going to probably lead to a particular answer, but then we can talk about it. Would you want your family member to have a TAVI in a hospital without on-site cardiac surgery?
Very important question. So we have this, the answer is no. We have some difficulties.
Okay, hold on. Francesco,
okay.
Yes or no? And then you're going to
It depends. It depends. I mean, my grandmother she was 98, no problem to treat in the
Okay,
center.
in general, would you want your family member?
If it's a low
we're not
risk,
talking about
75,
98-year-olds.
no.
Okay. No.
No.
No. Okay. Go ahead, Antonio, you were going to say?
No, because this problem is emphasized in literature, but I think it's practical. So we don't see differences in terms of mortality if we compare on-site versus not on-site cardiac surgery, but we need huge numbers. And sometimes if we have some complications, the cardiac surgery on-site can face this complication and can solve the complication. So
okay.
I think that, stop. Basta, finito.
Okay. Next question that came up in the next topic was, maybe Maddie, do you think we should be triaging patients? Because there's so many patients coming to us. Is it a first come, first served basis at your hospital? Are you using some triage, using low to high risk type of patients who might deteriorate? Should we be adapting our heart team discussions? Maybe not even discussing some patients because they're extremely low risk and straightforward. What are your thoughts about that?
Well, so I think you should, at least let the heart team see the patient once, right? So discuss the patient. Might be a very brief conversation, like, look, this is clear TAVR case, this is clear surgical case. So, but triaging them, I was hoping to ask you guys a question because we have the problem of a long waiting list. And then the problem is you have emergent cases coming in. So what do you do then? That's really difficult for us. So what we try to do is we have patients that we say, this is really an emergency, no matter what. We're going to reschedule somebody else. We're going to treat them tomorrow or the day after tomorrow. And then we have patients that we see in a heart team, very severe aortic stenosis, syncope once or twice. So like very clear risk factors that indicate if I put him at the end of the waiting list, that's going to be too long for that patient. And so we are trying to triage it. There might be, maybe AI tools or other scores that can help you to triage them even better. But I think the longer you're waiting list, the more challenging it is to address this because you're going to have more emergency cases coming in. If your waiting list is 3 months, then it's just 4 weeks. So I think it's a really difficult question, but long answer short, I think you should triage your patients.
Okay, and so we got, and I guess, Antonio, what is the biggest bottleneck in your hospital for...
I think it's let's call it pre-screening. In all the patients, we are not super big center. We do 200 TAVRs per year. So almost the patients comes for a daily hospitalization when we do CT scan, echo, we screen the carotids, HEG, etc. And so this is one of the most limiting factor for the further expansion in the numbers. I mean, it's one of the key elements that reduce, the number of TAVR that we can perform.
Good. Excellent. I think for the sake of time, very nice discussion, I would say, but we have to move on. So we're going to talk about PCI, post-TAVR, and we're going to learn some more about tips, tricks, and pitfalls. I think you made some very nice simulations to show how we have to deal with that. I think we see more and more patients that get a TAVR valve quite young, but will get coronary disease, so we need to treat them afterwards. So please go ahead.
Thank you so much for this big opportunity. So first of all, if we want to be able to engage properly the coronary artery, I think we need to have a deep dive inside of the structure of the Evolut FX Plus because there are some new features that allow us to perform a safe, cannulation. We have this skirt, which is roughly 30 millimeters. We have these big access windows, which are located in front of the coronary. And fluoroscopically talking, you see that they are located between the node 3 and node 7. Of course, we have the C-tab, in which we are familiar with, and we have also these small markers which are located below the commissure around at the 3 millimeters. So it's very easy to understand if a valve is aligned or not. First of all, what I look at is the location of the C-tab. If we move cranially or caudally and the C-tab moves up or down, we can make sure that the valve is in the proper position. You see here that we tilt the valve in caudal cranial position and the C-tab goes up in the caudal position while the C-tab goes down in the cranial position. So it means that the valve is appropriate as positioning. So valve aligned in the epi projection, which is a good projection to understand if the valve is aligned, we should look at the C-tab, which should be located in front of us. And you see that in the green box, we can see the axes for the right coronary artery, and for the left here, you don't see the left because it's just facing towards the left coronary. We should look at these two markers you see that are located and are very close to each other, meaning that we have a good superimposition of the commissure. And if we move to the cusp overlap, you see that we have a translation of all these markers. So the C-tab will be located here, and we will have a superimposition of the two big windows you see that are both located one in front of the other, and the two markers which are just here are located on the right side. So another important aspect is to perform a baseline orthography just to understand also what is the location of the valve compared to the native anatomy. And if you look at this video, you see that we have those two markers here, the big window in front of the left cusp, and we have this other window which is located just in front of the right cusp. And of course, also the C-tab is facing toward us. So this means that the valve is appropriately aligned. But let's go to the cannulation. Essentially, as you can see here in the video, we go AP or slightly LAO. We advance the wire just to make sure that the valve is within the valve frame, and then we advance our catheter. And every time we try to reposition the guiding catheter, we have to make sure that the wire is ahead. And once we are in front of the left coronary artery, we do an injection, of course, as you can see here. We can use both the left jackins or the ABU, not undersized. Same thing also for the RCA. You see that with the big cell, big windows, it's very easy to get that proper access, as Matti pointed out previously in the presentation. So the cannulation is no longer an issue. And you see here that with the very fine movements, fine-tuning, we can engage the big window, we can inject the contrast. It's not necessarily to be perfectly engaged inside of the corner, but we can advance a coronary wire, as done in this case, you see, and then we can pull back slightly the guiding catheter to make sure that we are perfectly inside of the ostium. And once you see that we are in this position, it's not an issue also to advance some other materials like a balloon in this case. But what about a misaligned valve? Like in this case, you see we have the markers here around the RCA. We have the C-tab who is not facing us. So we have a completely misaligned valve in this case. As you can see, also by the angiography, you see that we have the big cells just pointing toward us, but the left coronary artery is here. So it's not impossible to cannulate in this case. Again, also for the left, I go AP or slightly LAO. And here you see that the RCA is cannulated just engaging the right sinus. After the engagement of the right sinus, we can advance a wire. Preferably, maybe we can use an hydrophilic guide wire just to make sure that we can bend the wire and we can advance the wire inside of the coronary. And again, it's useful also to use some guide extension, maybe to increase the support that we need. And finally, you see that the same thing is useful also for the left coronary. Again, we advance our catheter, the Judkins left or the ABU. We make always an injection to make sure that we are in the right position. And once we achieve and we engage the left sinus, we can again advance a wire, and we can require more. If we require more support, we can advance even a guide extension. And I think that the PCI is done. Thank you so much.
Excellent. Excellent demonstration, very nicely visuals. I think for the sake of time, we're running a little bit behind. We have to move forward, and then hopefully we have a little bit of time for discussion. So I'd like to ask Matty to come back to the stage again and talking about how to revolutionize the efficacy. So how we're going to use AI or dashboards or other screening tools to help us to optimize our flow.
Yeah, thank you. So I have to admit that was a fun presentation. I mean, fantastic pictures, fantastic videos, tough talk to follow, right? So that was great. But I'm trying to, impress you guys with another thing, right? So first of all, how can we use new technologies and AI or data management to improve our pathways? And that's kind of the question of this talk. And to be like the potential that is there is, look at this video. I'm an interventional cardiologist. It took me 3 minutes to do this video. So it's like you prompt it, you get it, right? So we have technology at our hands that can help us in our pathway. And so there are some diagnostic tools, and I just picked some, and it's actually fun to look around what's already there. So imagine, again, AI-created picture, right? Cardiologist in a dark room looking at echoes. And if you do that, all of us, we've felt that pain, I think, but there's already an AI mechanism that looks at your echo pictures and will predict exactly the same as you did, right? So the correlation coefficients are high for your velocity, for your gradient, for everything. But further, take this one step further. This is an AI algorithm that will just look at a long axis. It's just that view, nothing else. And the prediction for aortic stenosis is area under the curve 0.952. So just with that video, AI can predict if you have aortic stenosis or not. And then there's another tool where you just look at, it's only the echo report, and no LVOT measurements were done in this echo report. So just looking at echo data and a trained AI algorithm, the algorithm can actually identify not only the patients with severe aortic stenosis, but it will find 3% of moderate AR patients, moderate AS patients that are at higher risk and that should be treated because they have the same prognosis than severe aortic stenosis patients. So that's diagnostic tools. There are more tools coming up, and I think it's a very interesting field. There are also procedural planning tools. So, for example, that's one tool that we use in our hospital as well. It's called Lara Lab. So you upload your CT, and then without having done even one click in the CT, you will have annular measurements, you will have coronary heights, you will have STJ measurements. You can even have septal length, membranous septal length, all that stuff. You have, without even clicking in a CT, you have annotated the full CT in 4D. You can look at the opening of the aortic valve. Everything is already in there. Imagine what that could mean to an optimized TAVR pathway, and also you have all the data available. You could actually control what your average diameter was in the last 2 years if you would use that. And that opens another field like controlling tools. So if you have data available, technology can help you to understand it and to visualize it. For example, one of the topics that we love to talk about are dashboards. And so, for example, imagine a dashboard, a tool that helps you taking data from your hospital system that is already there, no click done by you. It just takes data and it will show you, and that's just an example. How many procedures have you done? What was your mean age? What's the STS score? But also, what's your complication rate? So how much complications do you have in comparison to like the hospital next door, to everybody in Germany, to everybody in Europe? And what kind of complications do you have? And also, how is your procedure performance? Do you do transfemoral? Do you do ultrasound guided? All that stuff. So it's right there, and technology can help us to understand this and thereby promoting a better pathway for our patients. So taken together, I think if we could use some of the promising stuff that I found while looking and researching for that presentation. I think we'll be in a really interesting future. Thank you.
Okay, so what we're going to do is there's just one last burning question that I'm going to give to Antonio. It's going to be a basta finito type of question. So answer yes or no, and then Martin is going to finish off with closing remarks. And it's just to get back, I just want to ask the question. So someone who had that on-site surgery type of question said, now can you put the question this way, that your family member will rest on a long waiting list and maybe not perform TAVI very fast, or they would get a TAVI faster by going to a center without on-site surgery?
Stay in the waiting list.
Okay, go ahead.
Okay, fantastic session, I would say, and I think there's much more to discuss, as you can find out. There's a lot of things coming up, so we nicely started with the expansion of indications, new studies coming up, and we see an enormous amount of TAVR procedures coming up to us, and we've seen that waiting lists are already growing nowadays, and death on the waiting list is definitely something that is already an issue nowadays in a lot of countries. So we have to deal with it. We nicely saw the different lectures about how to optimize pre-hospital, in-hospital, and also at the end we saw that AI and dashboards and things are going to help us as well. But I think new TAVI coordinators or anything, we have to optimize our flow with or without cardiac surgery, we let in the middle, but I think we have to do something about. So I think many more will be discussed in the near future. So thanks a lot for joining this session, and I wish you a good Congress.
Thank you.